Imagine this. You're hit with all the terrifying symptoms of a heart attack. The crushing chest pain, the struggle to breathe, that overwhelming fear. You rush to the hospital. Doctors perform an angiogram, looking for the classic culprit, a blocked artery. But here's the twist. They find no blockages, not a single one. What if everything you thought you knew about heart attacks was missing a crucial, often invisible piece of the puzzle? That feeling of shock, that profound confusion. It's incredibly real for thousands of people, and it happens far more often than you might suspect. When the heart's main highways look clear, what could possibly be going on beneath the surface to cause such a critical event? That's the mystery we're diving into today. Welcome to the Deep Dive, where we're pulling back the curtain on one of cardiology's most fascinating and frankly often misunderstood conditions, myocardial infarction with non-obstructive coronary arteries, mercifully shortened to MINOCA.
That's right. In this deep dive, our mission is to decode MINOCA, to truly understand what it is, why it presents such a profound diagnostic challenge for clinicians and patients alike, and to explore the surprisingly diverse array of underlying causes that can lead to this unexpected form of heart attack. We aim to offer you a comprehensive understanding that goes far beyond typical discussions of heart disease, highlighting the intricate complexity that lies beneath the surface.
Before we plunge into the depths of MINOCA, we want to extend a huge, heartfelt thank you to London Heartbeat SCAD Academy, UK. Their invaluable educational support really made this deep dive possible. Their commitment to advancing cardiac knowledge is truly impressive, and we deeply appreciate their contribution. We encourage all of you who are curious listeners to explore London Heartbeat SCAD Academy's extensive catalog. They've got over 150 popular courses. You are truly bound to find something that sparks your curiosity and significantly advances your understanding of cardiac health. And of course, make sure you subscribe to their social media channels on Facebook, Instagram, and YouTube for free, regular updates. That way you ensure you don't miss future amazing discussions like this one. 2-second pause. Okay, let's get right into it. We're talking about a heart attack where, on the surface, the heart's main plumbing looks, well, fine. It sounds like it should be incredibly rare, almost like a medical oddity. How often does this condition, MINOCA, actually happen?
Yeah, you'd think so, but it's far from rare, and that's one of the truly surprising things about MINOCA. It actually accounts for approximately 5% to 6% of all cases of acute myocardial infarction, or AMI.
Wow.
Think about that. Out of every 100 people who experience a heart attack, 5 or 6 of them will present with this condition where their major coronary arteries are found to be non-obstructive.
Yeah.
That's a significant portion, enough to demand serious attention in clinical practice.
5 to 6%. That's really not negligible at all. It definitely shifts our perspective from just thinking about completely blocked arteries.
Mm-hmm.
So what does this statistic imply for how doctors approach diagnosis and treatment? If the usual blockages aren't there, the standard heart attack playbook must kind of go out the window.
Precisely. This prevalence means there's a critical need for a much more refined and, frankly, investigative diagnostic approach. You can't just stop at looking for plaque. For this significant chunk of heart attacks, the traditional understanding of blockages just doesn't apply. It forces clinicians to think much more broadly, to investigate deeper, and to consider a wider range of underlying causes that we'll definitely get into. It also means that initial treatment strategies might need adjusting once MINOCA is suspected or confirmed, because simply opening a blocked artery, which is, the cornerstone of traditional heart attack treatment, isn't the answer here.
Okay, so it's not rare, and it's clearly complicated. How do doctors actually define MINOCA? Is it just any heart attack without blockages, or are there really specific, strict criteria involved?
Oh, it's definitely not just any heart attack without blockages. MINOCA is a very specific clinical diagnosis. It requires fulfilling what we sometimes call a triple threat of criteria. First, the patient must clearly meet the criteria for acute myocardial infarction, as defined by the fourth universal definition of myocardial infarction. This generally means there's clear evidence of myocardial injury, usually detected by abnormal cardiac biomarkers like elevated troponin levels. And this needs to be in conjunction with evidence of myocardial ischemia. Ischemia meaning lack of blood flow? Exactly. Lack of blood flow causing symptoms like chest pain or new changes on an electrocardiogram like ST segment deviations, or even imaging evidence showing new loss of viable heart muscle or new regional wall motion abnormalities. The crucial point here is that it is a true heart attack. Heart muscle cells have died. It's not just a minor blip on a blood test.
Right, so it's a confirmed heart attack. What's the second criterion then, the one about the arteries looking clear?
The second, and probably the most defining criterion, is non-obstructive coronary arteries. This is a key finding determined by specific angiographic guidelines. It means that when doctors perform an angiogram, they find no lesions, no narrowings, of 50% or greater in any major epicardial vessel. Those are the big surface arteries. And it's really vital to emphasize what non-obstructive truly means here. It doesn't necessarily mean the arteries are perfectly normal or pristine. It just means they are not obstructively narrowed by significant plaque. There might be some mild disease, maybe some irregularities, but nothing that would typically be considered flow limiting. This distinction is crucial because it immediately shifts the focus away from obvious large vessel blockages to more subtle issues.
Okay, makes sense. And what's the third leg of this diagnostic stool? What else needs to be ruled out before a doctor can confidently say it's MINOCA?
The third criterion is no other overt cause. This is super important because MINOCA is largely what we call a diagnosis of exclusion. This means you have to definitively rule out any other clinically obvious, specific cause that could offer a more straightforward explanation for why the patient is acutely unwell.
Like what kind of things?
Well, for instance, if a patient comes in with chest pain and elevated troponin, but they also have severe sepsis, a major body infection, or maybe a massive pulmonary embolism, a big blood clot in the lungs, those severe conditions are themselves capable of causing myocardial injury and troponin release. In such cases, the diagnosis would lean towards those overt causes, not MINOCA. This criterion ensures we're not misattributing the heart damage when a more direct cause is staring us in the face.
Got it. So you have to be incredibly thorough. What are some of those other conditions that might mimic MINOCA, or that doctors absolutely have to exclude before landing on that diagnosis? It sounds like a bit of a diagnostic maze.
You're absolutely right, it can be. There are critical steps to rule out other conditions. First, as we just touched on, are those clinically overt causes for the elevated troponin. We mentioned sepsis, massive pulmonary embolism. These systemic conditions put immense stress on the heart, causing injury. They must be considered and dismissed as the primary cause before thinking MINOCA. The patient's whole clinical picture is key.
Okay, so those are the big, obvious systemic causes. But what about things that might look like MINOCA on the initial angiogram, but are actually just very subtle forms of traditional heart disease that were maybe overlooked?
That's the second really important exclusion, clinically overlooked obstructive disease. It happens. Sometimes, significant obstructive disease can be incredibly subtle and easy to miss on a standard angiogram, especially if the first look isn't super meticulous. For example, you might have a complete blockage of a very small coronary artery branch, maybe due to a tiny plaque disruption or a small clot fragment located way down in the vessel where it's hard to see clearly. Or maybe there's an overlooked stenosis of 50% or more in a distal part of a main artery. It might not jump out initially, but on closer review, perhaps with different camera angles, it's actually a flow-limiting blockage. This really underscores why a careful, thorough examination of the entire coronary tree is just paramount. What looks non-obstructive at first glance might not be.
And that third category you mentioned earlier, those clinically subtle, non-ischemic mechanisms, what kind of conditions are those that could confuse things?
Right. These are other causes of heart muscle injury that don't involve ischemia in the traditional sense, but can present like a heart attack with chest pain and raised troponin. But crucially, they aren't MINOCA because they have a different primary cause. This category kind of sets the stage for conditions that often do end up being diagnosed under the MINOCA umbrella because they lack obstructive coronary disease, but need specific identification for the right treatment. Think of things like myocarditis, which is inflammation of the heart muscle itself, or stress-induced cardiomyopathy, takotsubo, the broken heart syndrome, or even a true supply-demand mismatch where the heart muscle is injured because its oxygen needs to drastically outstrip its supply, even without a primary artery blockage. Pinning down the precise cause among these is essential.
So MINOCA patients are clearly a unique group compared to those with the more common heart attacks caused by blockages. Do they tend to have any special features or a typical profile that kind of sets them apart?
They absolutely do. They have distinct characteristics. For one, thinking about their ECG presentation, MINOCA can present with or without ST segment elevation, which is that classic ECG finding in many heart attacks. However, it's generally less likely to show those really pronounced ST segment deviations compared to heart attacks from obstructive disease. This more subtle ECG can sometimes make the initial diagnosis a bit trickier.
Interesting. And what about troponin levels, those heart damage markers? Are they similar to typical heart attacks, or is there a difference there too?
Not always the same, no. MINOCA often involves smaller degrees of troponin elevation. While the troponin is definitely elevated, clearly indicating heart muscle damage, the levels might not shoot up as dramatically as you'd see in a big obstructive heart attack. This, again, can add to the diagnostic challenge. It might initially be dismissed as maybe less significant without that deeper investigation into the why.
That's really fascinating. What about the demographics? Are we talking about the same sort of people who typically get heart attacks, older individuals, maybe with a history of heart issues?
Not exactly. MINOCA patients tend to be younger than those with obstructive coronary artery disease. That's a pretty significant difference right off the bat. And even more strikingly, there's a pronounced gender disparity that's really important to highlight. Women account for up to 50% of the MINOCA population.
50%.
Yeah. Compare that to acute myocardial infarction with coronary artery disease, AMICAD, where women represent only about 25% of the population. So women are disproportionately affected by MINOCA. This has huge implications for recognizing, diagnosing, and managing the condition in female patients who are, unfortunately, often underdiagnosed for heart disease generally.
That is a massive difference, 50 versus 25%. And what about the traditional risk factors we always hear about, like high cholesterol or diabetes? Are they just as common in MINOCA patients?
Here's another surprising twist that really challenges common assumptions about heart disease. MINOCA patients tend to have a lower prevalence of dyslipidemia that's high cholesterol. This is in stark contrast to typical obstructive CAD, where high cholesterol is a major, well-known risk factor. And additionally, other traditional CAD risk factors, things like hypertension, diabetes mellitus, tobacco abuse, even a family history of heart attack, they're also less frequently observed in MINOCA patients. It really challenges our usual framework for thinking about who gets heart disease and why. It highlights that MINOCA is a distinct entity, not just, say, a milder form of traditional CAD. It means we have to look beyond the usual suspects when assessing someone's cardiac risk.
Okay, time for a quick knowledge check for you listening. See how these unique characteristics are sinking in. MCQ 1. Which of the following is not a typical characteristic of MINOCA patients compared to those with obstructive coronary artery disease? A. They're usually younger. B. They often have smaller degrees of troponin elevation. C. Women make up a significantly larger percentage of the MINOCA population. D. They tend to have a higher prevalence of dyslipidemia. 2-second pause. Now that we have a better handle on what MINOCA is and who typically affects, let's dive into why it happens. One of the key underlying mechanisms you mentioned sounds pretty dramatic: plaque disruption. Tell us more about this silent threat.
Indeed, plaque disruption might sound dramatic, but it's a critical, often silent process that underlies many MINOCA cases. It's actually an umbrella term covering 3 distinct ways a plaque can cause trouble: plaque rupture, plaque erosion, and something called calcific nodules. Regardless of the specific type, the general sequence is usually the same. The plaque becomes unstable, it disrupts, and this leads to the formation of a blood clot, a thrombus, which then triggers the acute myocardial infarction. The damage to the heart muscle, the myonecrosis, occurs even if that clot isn't big enough to create an obvious visible blockage on the angiogram.
So how does the heart muscle actually get damaged if there isn't a major blockage starving it of oxygen in the usual way?
Right, the heart muscle cell death, the myonecrosis, in these MINOCA cases often happens through more subtle mechanisms than a complete artery blockage. This can include what we call distal embolization. Tiny microscopic fragments of the clot break off from that disrupted plaque and travel downstream, blocking much smaller, more peripheral vessels too small to see on an angiogram. Or it could involve a superimposed coronary spasm, where the artery temporarily clamps down, constricts, even without a fixed blockage, squeezing off blood flow. Or sometimes there's transient complete thrombosis with spontaneous thrombolysis. Basically, a clot forms, maybe even blocking the artery completely for a short time, but then it dissolves on its own before it causes a permanent visible obstruction, but not before it causes enough transient lack of blood flow to injure the heart muscle. It's a very dynamic process.
Let's break down those 2 main types you mentioned, plaque rupture versus plaque erosion. What's the fundamental difference, and why does that distinction actually matter for understanding and maybe treating MINOCA?
Yeah, the distinction matters quite a bit for understanding the underlying pathology and guiding treatment. Plaque rupture is defined as a fibrous cap discontinuity. Imagine a thin, protective cap over a fatty deposit in the artery in rupture. That cap tears open. This exposes the highly reactive fatty material inside the plaque directly to the bloodstream, which immediately triggers clot formation. Plaque erosion, in contrast, is defined as a blood clot that's right up against the inner surface of a plaque, but without any signs of that fibrous cap actually rupturing. Crucially, plaque erosion is thought to be a distinct process, primarily caused by damage or dysfunction of the endothelium, the inner lining of the blood vessel itself. This is a key difference from plaque rupture, which is largely driven by inflammation within the plaque, making the cap weak and prone to tearing.
Can doctors actually see signs of this disruption on a standard angiogram, or is it really often invisible to the naked eye, so to speak?
Well, the angiographic appearance might suggest plaque disruption, but it's often very subtle. You might see a faint haziness, maybe a tiny filling defect. It hints something is there, but it's not necessarily an obvious obstruction. But for a definitive diagnosis, plaque disruption can only really be confirmed with specialized intracoronary imaging. Standard angiograms just don't have the resolution needed.
So to really get to the bottom of it, you need to look inside the artery with more powerful tools.
Exactly. For a definitive diagnosis, we turn to advanced intracoronary imaging techniques. These let us see inside the artery with incredible detail. Optical coherence tomography, OCT, is generally the preferred method. It has significantly higher resolution. Think of it like a microscopic camera visualizing the plaque and vessel wall layer by layer. It can clearly show if a cap has ruptured or if there's an eroded surface. Intravascular ultrasound, or IVUS, is another valuable tool, although it provides somewhat lower resolution compared to OCT. These tools are absolutely critical for understanding what's really happening when the angiogram looks normal.
You also mentioned calcified nodules as a type of plaque disruption. What are those, and what role do they play?
Right, a calcified nodule is basically what it sounds like, a hard, calcium-rich deposit. On OCT imaging, it shows up as a signal-poor region with poorly defined borders that actually protrudes into the arterial lumen. It's like a hard, bony bump inside the artery. This can disrupt blood flow, or more often, lead to clot formation as blood becomes turbulent flowing over it. It's actually the least common cause of plaque disruption we see, and it tends to be more prevalent in older patients. And specifically regarding MINOCA, plaque erosion can play a really important role. Because there's no obvious blockage in the main arteries, the heart muscle damage might well result from those tiny distal embolizations we talked about, microscopic clot fragments breaking off the erosion site and blocking tiny downstream vessels.
Okay, so once plaque disruption, in whatever form, is identified or strongly suspected as the cause of MIOCA, how is it managed? What's the treatment strategy when you can't just stent open a big blockage?
Good question. In the acute phase, right after the disruption, the focus is on preventing more clotting. So antiplatelet agents like aspirin and potentially anticoagulants are used. The goal is to limit that thrombotic response, stop the clot from growing bigger. You want to prevent a small clot on the vessel wall, a mural thrombosis, from progressing to an occlusive thrombosis, which would cause a complete blockage. For long-term therapy, if plaque disruption is suspected or confirmed in MINOCA, patients are typically recommended dual antiplatelet therapy, 2 different antiplatelet meds for 1 year. This is then usually followed by lifetime single antiplatelet therapy. This regimen helps prevent future clots forming on that vulnerable plaque. Now, if, despite this, an occlusive clot does form, then clot-dissolving medication, thrombolysis, or mechanical intervention like angioplasty might still be needed to reopen that artery.
Beyond stopping the immediate clot, what about preventing future problems? How do you stabilize these vulnerable plaques so they don't cause trouble again?
That's where the crucial concept of plaque stabilization comes in. The primary agents for this are lipid-lowering drugs, especially statins. They do more than just lower cholesterol levels. They actively work to stabilize the plaques themselves, making them less prone to rupture or erosion. This involves several complex changes within the plaque at a cellular level. For instance, you see a rapid normalization of endothelial function. The inner lining gets healthier. Inflammatory cells, like macrophage foam cells, tend to disappear from the lesions. And the soft, fatty lipids inside the plaque, particularly cholesterol esters, get depleted. This results in a smaller, stiffer, less vulnerable lipid core.
So the plaque becomes less squishy and less likely to burst.
Exactly. You also get an increase in mature collagen, which acts like scaffolding, strengthening the fibrous cap over the plaque. The overall outcome is often a larger vascular lumen, more space for blood flow, and a modified, but interestingly, not necessarily smaller, plaque. That's a key point. Stabilization doesn't always mean shrinking the plaque. It means making it less dangerous, less likely to cause an event.
And beyond medication, What lifestyle factors play a critical role here in preventing plaque disruption and stabilizing these plaques?
Lifestyle is absolutely paramount. And among all factors, cigarette smoking really stands out as a key trigger for plaque disruption. It's important to understand that smoking contributes to disease progression not just through chronic plaque buildup over years, but also through acute triggering mechanisms. These include directly causing plaque disruption, promoting new clot formation, and causing temporary vasoconstriction where blood vessels tighten up. Smoking directly impairs endothelial function, that vital inner lining, and promotes lipid oxidation, both making plaques more vulnerable. So quitting smoking is probably one of the single most powerful things someone can do to stabilize plaques and drastically cut their risk of another event. It's foundational.
Okay, let's test your understanding again about these silent threats. MCQ2. What is the primary difference between plaque rupture and plaque erosion as causes of plaque disruption? A. Plaque rupture involves a thrombus without signs of a fibrous cap break, while plaque erosion involves fibrous cap discontinuity. B. Plaque erosion is primarily caused by inflammation, while plaque rupture is caused by endothelial erosion. C. Plaque rupture involves a fibrous cap discontinuity, while plaque erosion involves a thrombus contiguous to the luminal surface without rupture. D. Plaque rupture is diagnosed with IVUS, while plaque erosion is diagnosed with OCT. 2-second pause. All right, moving on from plaque disruption. Let's shift to another cause that can feel just as dramatic but has a very different mechanism. Vasospastic angina. This condition used to have a more, poetic name, didn't it?
It did indeed. It was previously known as Prinzmetal angina or variant angina, names that kind of capture its unpredictable nature. Its key features are episodes of rest angina, that means chest pain occurring spontaneously, often severely, while at rest, not necessarily during exertion. And crucially, these episodes respond very promptly to short-acting nitrates, like nitroglycerin. That quick relief is a hallmark.
And even though the arteries look clear on an angiogram, this condition can still have really serious consequences, almost like a regular heart attack.
Absolutely. Coronary spasm, the main event in vasospastic angina, can be associated with significant, even life-threatening risks. These include acute myocardial ischemia, severe lack of blood flow causing pain, acute coronary syndromes, potentially including actual heart muscle damage, dangerous arrhythmias or abnormal heart rhythms, and even sudden cardiac arrest. So while there's no fixed plaque blockage, that temporary severe constriction of the arteries can be incredibly dangerous.
What actually causes these dramatic spasms? It sounds like the artery just decides to clamp down on its own. Is it a nerve issue or something within the artery wall?
It's typically a complex interplay of factors. It often involves an imbalance in the autonomic nervous system. We frequently see increased vagal tone, that's part of the system that slows things down, and also hyperreactivity to sympathetic stimulation, the fight or flight response. Interestingly, these variant angina episodes often happen between midnight and early morning, which is exactly when vagal tone is naturally highest. Environmental factors also play a big role, things like smoking, certain metabolic issues, alcohol consumption. And there seems to be a genetic predisposition too, with several gene variations implicated.
You mentioned the nervous system, but what about the blood vessel itself? How do the cells lining the artery contribute?
Yes, the vascular endothelial cells, that delicate inner lining, are absolutely key. In a healthy artery, a crucial molecule called nitric oxide, or NO, is produced by an enzyme called eNOS. This eNOS releases NO when activated by signals like the shear stress of blood flow. And NO is a powerful vasodilator. It tells the blood vessel to relax and widen. However, in vasospastic angina, the hyperreactivity of the coronary arteries seems often due to a lack of sufficient baseline production or release of NO from the endothelium in those affected arteries. Without enough NO, the vessels lose that crucial ability to relax properly, making them prone to spasm.
And then what about the smooth muscle cells in the artery walls? How do they get involved and actually cause the tightening?
Right, the vascular smooth muscle cells are the ones doing the constricting. In vasospastic angina, there's often what we call coronary vascular smooth muscle hyperreactivity. This means these muscle cells are overly sensitive and prone to contracting. It involves an imbalance in certain enzyme activities within the smooth muscle cells, leading to a state where contraction processes dominate over relaxation processes. The end result is excessive, uncontrolled, smooth muscle contraction, the spasm.
If the arteries look clear on the standard angiogram, how do doctors actually confirm this diagnosis? Are there special tests?
Yes, exactly. Because the problem is dynamic, not fixed, specific provocative tests are often needed to confirm vasospastic angina. The drugs most commonly used clinically in these tests are acetylcholine, or ACH, and ergonovine, or ER. These substances are carefully given, usually directly into the coronary arteries during an angiogram procedure, to see if they can induce a spasm under controlled conditions.
How does that invasive testing actually work? What counts as a positive result confirming a spasm?
A positive response is defined very specifically. It involves seeing a transient occlusion, a sudden, severe narrowing of more than 90% in a coronary artery. And this narrowing must be accompanied by the patient's typical signs and symptoms of myocardial ischemia, like their usual chest pain, or significant ST segment changes on the ECG. It's about reproducing the event safely.
Let's talk about ergonovine first. How does it work, and what are the risks?
Ergonovine primarily acts directly on the smooth muscle cells, activating certain receptors that cause vasoconstriction tightening. It also affects the endothelium in complex ways. But it's important to know that adverse reactions can occur. These can range from angina and ischemia to, rarely, myocardial infarction, arrhythmias, nausea, allergic reactions, or a condition called ergotism. So these tests require very careful monitoring and immediate access to reversal agents.
And acetylcholine, how does that differ in mechanism, and what are its risks?
Acetylcholine acts on both the endothelium and the smooth muscle. In a healthy artery, ACH actually causes vasodilation via the endothelium producing nitric oxide. However, in patients with endothelial dysfunction, which is common in vasospasm, the endothelial cells don't produce enough NO, so ACH ends up causing contraction instead of dilation, the spasm. ACH also has potential side effects like temporary drops in blood pressure, slower heart rate, shortness of breath, flushing. Serious reactions are rare but possible, like ventricular tachycardia or shock, so again, careful monitoring is essential.
So there's a very specific protocol for doing the acetylcholine test.
Absolutely. It's precise. It involves giving incremental doses of acetylcholine over 3 minutes each, usually into the left coronary artery. Starting low, say 2 micrograms, then 20, 100, up to 200 micrograms. If that's negative, a smaller dose, maybe 80 micrograms, might be given into the right coronary artery after a pause. Crucially, nitroglycerin is given immediately if a spasm occurs to reverse it, or at the end of the test regardless, just to be safe and return the vessels to baseline.
And how do they interpret those results? Can they tell the difference between a spasm in a large artery versus the tiny microvessels?
Yes, the interpretation is quite specific. It's considered positive for epicardial coronary spasm if there's a 75% or more narrowing of a large vessel, along with the patient's typical angina and ischemic ECG changes. But there's also something called microvascular spasm. This is diagnosed when there's no significant epicardial spasm, less than 75% narrowing, but the patient still gets their typical angina and ischemic ECG changes, like ST depression or elevation or T wave changes. It's a key distinction pointing towards problems in the smaller unseen vessels.
That sounds incredibly detailed. How reliable are these provocation tests?
They generally have good sensitivity. Sensitivity is reported as 100% when angina is part of the diagnostic criteria and still very high, around 94% just looking at ST segment elevation. So they are quite effective at identifying spasm when used correctly. You can sometimes even see visual evidence on the angiogram itself, like a major artery visibly narrowing after the acetylcholine infusion.
Are there any non-invasive ways to check for spasm, maybe avoid the invasive procedure?
Yes, there are non-pharmacological, non-invasive methods that can provide clues or support the diagnosis. These include getting a standard 12-lead ECG during an episode of chest pain, which might show temporary changes. Holter monitoring, wearing an ECG recorder for 24 hours or more, can sometimes capture episodes. Exercise testing occasionally provokes spasm, though it's less common. And even hyperventilation testing, having the patient breathe rapidly, can sometimes induce changes suggestive of spasm in susceptible people. These are often used as initial screens or supporting evidence.
Okay, so once vasospastic angina is diagnosed, what are the treatment strategies? How do you manage this unpredictable condition?
Right. Management starts with lifestyle, especially quitting smoking if the patient smokes. That's critical because smoking is a major trigger. The mainstay of medical treatment for vasospastic angina is calcium channel blockers. This class includes drugs like nifedipine, amlodipine, diltiazem, verapamil. They work by relaxing the smooth muscle cells in the coronary arteries, helping to prevent and relieve spasms.
What about nitrates as standard angina treatment? Do they fit in here too?
Yes, definitely. Short-acting sublingual nitrates under the tongue are excellent for stopping acute attacks quickly. They provide immediate relief by dilating the vessels. Long-acting nitrates are also useful, but more for preventing attacks over the long term. And interestingly, statins, the cholesterol drugs, have also shown benefits in reducing major adverse cardiac events in these patients. This is likely due to improving endothelial function and reducing inflammation, even if cholesterol is the main issue.
Is revascularization, like stents or bypass surgery, ever done for vasospastic angina?
Generally, no. Revascularization is usually contraindicated unless there happens to be a significant fixed blockage from plaque present as well that needs treating. The problem in pure vasospasm isn't a fixed blockage, it's the dynamic constriction. Stenting an artery that isn't structurally blocked doesn't solve the underlying spasm issue. As for beta blockers, their role is a bit tricky. While they can help if there is an associated fixed blockage by reducing heart workload, non-selective beta blockers should be used cautiously. They might theoretically worsen spasm by allowing unopposed alpha receptor effects that constrict vessels, so medication choice needs to be very careful and individualized.
Let's test your knowledge again and see how much of this intricate information you've picked up. MCQ 3. Which type of angina is characterized by episodes of rest angina that promptly respond to short-acting nitrates? A. Effort-induced angina. B. Vasospastic angina. C. Microvascular angina. D. Stable angina. MCQ 4. Which of the following is considered the mainstay of treatment for vasospastic angina? A. Beta blockers. B. Revascularization. C. Calcium channel blockers. D. Dual antiplatelet therapy. 2-second pause. We've covered plaque disruption and artery spasms. Now let's move to an even more subtle cause of chest pain and ischemia, microvascular dysfunction. This is where the problem lies in the tiniest, often unseen vessels of the heart. You mentioned many patients have symptoms but show no visible blockages on angiography. How common is this hidden problem and what's its real impact?
It's surprisingly common and often underrecognized. Microvascular angina, the chest pain linked to this dysfunction, accounts for at least 1/3 of angina cases where there's no obstructive coronary artery disease seen on the angiogram.
A third. That's huge.
It really is a huge proportion of patients presenting with chest pain. And the clinical impact isn't trivial either. Patients diagnosed with coronary endothelial dysfunction, which is a key part of microvascular dysfunction, show a 20% higher rate of major cardiovascular events. That includes death, heart attacks, stroke, needing revascularization down the line. So it's not benign. It has serious consequences.
Okay, if it's so significant, how do doctors define it? Since the problem vessels are invisible on standard tests, what are the criteria for diagnosing coronary microvascular dysfunction, or CMVD?
CMVD is defined by 3 core elements. First, the patient has typical stable angina chest pain, mainly brought on by effort. Second, they have normal or near normal coronary arteries on angiography, no major blockages. And third, there's no other specific heart disease, like variant angina or valve problems, that could explain the symptoms. But beyond those clinical features, CMVD also requires objective evidence of myocardial ischemia found during diagnostic tests. This could be things like ST segment depression on an ECG during stress, or reversible perfusion defects seen on a stress nuclear scan, or even documented abnormalities in coronary blood flow during stress, measured using advanced techniques like cardiac MRI or PET scans. Metabolic evidence of ischemia can also contribute. You need that objective proof the heart muscle isn't getting enough oxygen.
It sounds like something doctors should be very aware of then. So why is it still often poorly understood or missed in practice?
Yeah, it's a challenge for a few main reasons. The biggest one is simply that the abnormalities in the small coronary arteries, the microvasculature, just cannot be seen by standard angiography. You can't directly visualize the problem with the most common tool. Second, really assessing the microcirculation function properly during an invasive procedure requires complex and time-consuming methods that aren't routinely done for every patient. It's not a quick test. And third, in many patients suspected of microvascular angina, the usual signs of ischemia we look for, like changes in how the heart wall moves during stress or release of certain chemicals from the heart muscle, are often undetectable with standard tests. This makes it very elusive.
Why are those signs, like changes in heart muscle movement, often undetectable in CMVD when they're usually clear with a big blockage?
That's a great question, and it gets to the heart of the diagnostic difficulty. When a large artery is blocked, the lack of blood flow, the perfusion impairment, is usually pretty uniform within the area supplied by that artery. This leads to a detectable, segmental problem with contraction. A specific part of the heart muscle doesn't move well, and you can see that on imaging. But in CMVD, the abnormality might not affect all the microvessels in a region uniformly. Instead, it might be distributed in a scattered, patchy way throughout the heart muscle. This scattered distribution likely explains why it's so hard to see objective evidence of ischemia using standard tests. The damage is microscopic and spread out, not localized and obvious.
To really get this, maybe we need a quick anatomy lesson. Could you break down the coronary arteries into their different functional parts, from big to small?
Sure. We can think of the coronary arterial system in 3 functional compartments. First, the proximal compartment. These are the large epicardial coronary arteries you see on an angiogram. Diameters from about 0.5 millimeter up to maybe 5 millimeters. Their main job is capacitance holding blood volume. They offer very little resistance to overall blood flow. Think of them as the main highways.
The ones we usually focus on.
Exactly. Then the intermediate compartment. These are the prearterials, smaller, maybe 100 to 500 micrometers in diameter. Here you start to see a measurable pressure drop. They begin to regulate flow in response to shear stress and pressure changes. But importantly, they aren't under direct control by the heart muscle's immediate metabolic needs, partly because they're outside the muscle itself. They regulate flow, but not based on moment-to-moment oxygen demand.
And finally, the tiny ones where the real action and maybe the problem in CMVD happens.
Precisely. The distal compartment consists of the intramural arterioles, tiny vessels within the heart muscle wall, less than 100 micrometers across. This is where the biggest pressure drop occurs, showing their critical role in flow regulation. These tiny vessels are highly sensitive to local tissue changes, oxygen levels, waste products. They directly control perfusion of the capillaries, the final delivery points. This is where the fine-tuning happens, responding directly to the heart muscle's needs. And this is where dysfunction in CMVD often originates.
So if the microcirculation accounts for, was it 80% of the resistance, how does dysfunction there lead to problems that are so hard to detect?
Right, 80% of the total resistance. That means even subtle dysfunction in these tiny vessels can significantly compromise blood flow and cause ischemia. As we discussed, the blood flow abnormalities in CMVD are very different from a big blockage. With a blockage, you get that uniform deficit leading to a visible segmental problem. But in CMVD, the abnormality is scattered, patchy, and that patchy distribution is likely why it's so hard to pick up objective evidence of ischemia with standard diagnostic methods. The problem is diffuse and microscopic, not localized and macroscopic.
What are the actual root causes then? What leads to this microvascular dysfunction? Is it structural, functional, or something else?
It's really a mix of mechanisms, structural, functional, and even extravascular, meaning outside the vessel. On the structural side, CMVD is often linked with conditions like hypertrophic cardiomyopathy, where the heart muscle is too thick, and arterial hypertension, high blood pressure. These conditions can cause adverse remodeling of those intramural arterioles. Their walls get thicker, less flexible, less able to expand properly. This remodeling is often diffuse, affecting the whole left ventricle.
And the functional mechanisms, how the vessels behave.
Functional mechanisms involve issues that lead to either impaired dilatation, the vessels can't open up enough when needed, or increased constriction. Impaired vasodilation often involves problems with endothelium-dependent mechanisms. These are strongly linked to risk factors like diabetes, obesity, smoking. There can also be endothelium-independent impairment, meaning the smooth muscle itself doesn't relax properly, sometimes due to problems with signaling pathways like cyclic GMP production.
You also mentioned extravascular mechanisms. What does that mean for these tiny vessels? Extravascular mechanisms refer to forces outside the vessel squeezing them. This includes extramural compression. For example, in severe aortic stenosis, a narrowed valve, or hypertrophic cardiomyopathy, thick muscle, the surrounding tissue can physically compress the microvessels. Even high blood pressure can contribute indirectly. Another factor is reduced diastolic perfusion time. The heart muscle gets most of its blood during diastole, the relaxation phase. Conditions that shorten diastole, like very fast heart rates or prolonged contraction phases, as in aortic stenosis, limit the time for blood flow. The natural pulsal flow varies with heart pressures. Since flow is mainly diastolic, abnormalities in that phase, like higher pressures during contraction seen in hypertrophy, really impact perfusion. And this whole idea of the heart increasing blood flow on demand relates to coronary flow reserve, CFR, right?
Yes, exactly. Coronary flow reserve, CFR, is a key concept. It's defined as the maximum possible blood flow when the vessels are fully dilated, hyperemic flow, divided by the baseline resting flow. It measures the microcirculation's ability to ramp up blood supply to meet demand, like during exercise. A reduced CFR is a hallmark of CMVD, indicating the microvessels can't deliver enough blood when needed.
Another question for you, MCQ5. What percentage of total coronary resistance is attributed to the coronary microcirculation? A, 20%, B, 50%, C, 80%, D, 100%. 2-second pause. Okay, given how elusive CMGD can be, what are the subtle clues that should make a doctor suspect it? The symptoms, like chest pain, sound like they could be anything.
You're right. The angina symptoms often mimic obstructive CAD, which is part of the difficulty. However, microvascular angina should be suspected if the chest pain lasts for several minutes after the triggering effort stops, and/or if it responds poorly or slowly to nitroglycerin. That's different from typical angina, which usually resolves quickly. Also, a key finding during certain stress tests, like an echocardiographic dipyridamole or dobutamine stress test. If the patient develops angina and ECG changes, like ST depression, without any visible abnormalities in how the left ventricle is contracting, that's strongly suggestive of a microvascular cause. The patchy nature of the perfusion issue means the overall heart wall motion can look normal on the scan, even though the patient feels pain and has ECG changes.
If standard tests often aren't enough, what specialized assessments can actually reveal these hidden microvascular issues? How do doctors dig deeper?
When suspicion is high, we move to more specialized tests. There are both non-invasive and invasive options. Non-invasive methods include advanced imaging like Doppler echocardiography, myocardial contrast echocardiography, nuclear scans like SPECT or MRI, and sometimes CT scans. These can provide valuable clues. But for a more definitive, precise assessment, invasive methods are often needed. These involve using specialized wires during a cardiac catheterization, things like a Doppler flow wire, or a wire with temperature and pressure sensors that can measure flow directly inside the coronary arteries.
Let's focus on those invasive methods. What's considered a gold standard for assessing the microcirculation this way?
Coronary flow reserve, CFR, which we mentioned, is a key measure, and its invasive measurement is considered a gold standard approach. Remember, it's the ratio of maximum hyperemic blood flow to baseline flow. To get that maximum flow, clinicians use stress agents that cause endothelium-independent vasodilation. They directly relax the vessel's smooth muscle.
What are those specific stress agents and how do they work?
The common ones are adenosine, regadenoson, and dipyridamole. Adenosine binds to specific receptors on the smooth muscle cells, causing them to relax. Regadenoson is a more selective agonist, often used with perfusion imaging, and tends to have fewer side effects. Dipyridamole works indirectly by stopping cells from taking up the body's own adenosine, boosting its natural vasodilating effect. They all aim for maximal dilation.
Can you walk us through the actual adenosine test protocol? It sounds quite precise.
It is, yes. For the intracoronary test, it involves giving small, precise bolus injections of adenosine, say 18 micrograms in the left coronary, 12 in the right, diluted in saline, followed by a flush. You usually need at least 3 injections to ensure you get a stable maximal peak flow reading. Alternatively, stable hyperemia can be induced with intravenous adenosine, given as a continuous infusion, typically 140 micrograms per kilogram per minute via a central vein.
And what exactly are they monitoring during this test to calculate that flow reserve?
They use that special sensor tip guide wire, either Doppler or thermistor pressure sensor, placed in a healthy section of the artery. First, they measure the average baseline coronary flow velocity at rest. Then, after the adenosine causes maximum dilation, they measure the stable average peak flow velocity over a couple of heartbeats. CFR is then simply calculated as the ratio of that peak flow velocity to the baseline flow velocity. It tells you how much the flow capacity increased.
So how do they interpret that ratio? What CFR value suggests microvascular problems?
A positive result for coronary microvascular endothelium-independent dysfunction is generally defined as a CFR less than 2.5, assuming there's no significant blockage in the large artery being measured. A CFR below 2.5 indicates the microvessels aren't dilating enough to meet potential demand. Beyond CFR, endothelial function itself can be assessed, sometimes combining flow measurements with a cold pressor test, dunking a hand in ice water to see how vessels react.
Ah, yes, the cold pressor test. How does that work, especially when combined with hyperventilation stress echo?
Right. The protocol for hyperventilation and cold pressor stress echo aims to provoke the vessels. The patient hyperventilates for about 6 minutes, around 30 breaths min. Immediately after, they put their right hand in ice water for 2 minutes. That's the cold pressor. Throughout this stress, and for about 15 minutes after, there's continuous ECG and/or echo monitoring. A positive result, suggesting coronary vasospasm tendency, would be ECG changes like ST elevation or new wall motion abnormalities seen on the echo.
And what about the index of microcirculatory resistance, IMR? How does that compare to CFR? What are its advantages?
IMR is another important invasive measure, often seen as complementary or sometimes superior to CFR. It's calculated using distal coronary pressure, PD, and the mean transit time, TMN, of saline solution injected down the artery. The formula is PD times TMN. IMR was developed to overcome some limitations of CFR. Both pressure and transit time are measured with a pressure wire during full adenosine vasodilation. This approach potentially eliminates variability from resting vessel tone and isn't influenced by upstream blockages in the same way CFR can be.
So it might be more reliable or reproducible.
Exactly. Compared to CFR, IMR often provides a more reproducible assessment of the microcirculation itself, independent of overall hemodynamic changes like blood pressure shifts. Generally, IMR values greater than 25 units or CFR less than 2.0 are considered positive indicators of significant microvascular dysfunction.
Time for a couple more questions before we talk treatment. MCQ 6. Which invasive assessment method for coronary microvascular function measures the ratio of maximum hyperemic blood flow to baseline coronary flow? A. Index of microcirculatory resistance, IMR. B. Cold pressor testing, CPT. C. Coronary flow reserve, CFR. D. Hyperventilation stress echocardiography. MCQ 7. Which of the following is not a mechanism contributing to coronary microvascular dysfunction, CMD? A. Structural remodeling of intramural coronary arterioles. B. Impaired vasodilatation due to endothelial dysfunction. C. Extramural compression by conditions like aortic stenosis. D. Homogeneous distribution of myocardial perfusion abnormalities. 2-second pause. So once microvascular dysfunction is diagnosed, what can actually be done to treat this problem that's often so hard to pin down? Sounds challenging to manage.
It definitely presents challenges, but treatment focuses on several key areas. First and foremost, as with most heart conditions, is foundational lifestyle modification. That means things like a heart-healthy diet, regular physical activity, stress management. These are the cornerstones supporting overall vascular health, including the microvessels. Beyond lifestyle, specific medical interventions are known to improve endothelial function, which is critical here. These include, very importantly, smoking cessation. We keep coming back to that because it's so damaging to vessels. Weight loss, if needed, is also crucial. And medications like statins and angiotensin-converting enzyme inhibitors, ACEIs, are often used. They don't just manage cholesterol or blood pressure, they have direct beneficial effects on the endothelial lining, helping vessels function better.
And what about drug therapies specifically aimed at the symptoms, like that persistent chest pain?
Right. For symptom management, there's a range of drug therapies that can be tried, often tailored to the individual. These include calcium antagonists to help relax blood vessels, beta blockers used carefully to manage heart rate and oxygen demand, various forms of nitrates for relief and prevention. Also, drugs like nicorandil, which acts in a couple of ways to relax vessels, ranolazine, which helps the heart muscle use oxygen more efficiently, and sometimes even older medications like xanthines or imipramine might be considered for symptom relief. The choice really depends on the patient's specific symptoms and the suspected underlying mechanisms, requiring a personalized approach. 2-second pause.
Okay, we've covered plaque disruption, vasospasm, and microvascular dysfunction. Now let's explore some other specific, distinct causes of MINOCA. First is something called coronary slow flow phenomenon, or CSFP. This is when blood flow itself is sluggish, even without blockages. How's this defined?
CSFP is defined by observing delayed distal opacification of a coronary artery on an angiogram, specifically in the absence of any visible coronary artery disease. Basically, the contrast dye takes an abnormally long time to travel through the vessel, even though there's no obvious blockage slowing it down. It's not super common, accounting for maybe 1% to 7% of acute coronary syndrome cases overall. It seems to be more common in younger people, smokers, and men.
That's curious. What causes blood flow to be so slow if there isn't a physical blockage?
The exact reason, the pathogenesis, is still not entirely clear, and it's likely multifactorial. But several factors are implicated. These include functional and structural abnormalities in the microvasculature itself, similar to what we discussed in CMVD. Endothelial dysfunction is also suspected. Raised inflammatory markers are often seen. There might be occult hidden atherosclerosis that isn't obviously obstructive but still affects flow. Even anatomical factors of the large arteries might play a role. It's a complex puzzle.
How do doctors diagnose CSFP then if it's about flow speed, not blockages?
Diagnosis relies on specific angiographic measurements, mainly using either the TIMI flow grade or the corrected TMI frame count. A TMI2 flow grade, meaning flow is slow but eventually fills the vessel, can indicate CSFP if it takes more than 3 heartbeats to fill. A more precise method is the corrected TIMI my frame count. This involves counting the individual video frames it takes for dye to travel from the start of an artery, like the LAD, to a specific distal point. Images are usually shot at 30 frames per second. A count greater than 27 frames after applying a correction factor for the specific artery, like 1.7 for the LAD, is considered diagnostic. Different landmarks are used for the RC and LCX. It's about objectively quantifying that slow flow.
And how is CSFP typically treated? Can medications help speed things up?
Treatment aims to address the likely underlying microvascular issues and improve flow. Statins are often used for their anti-inflammatory effects. ACE inhibitors can help by directly modulating microvascular tone. Alpha blockers might reduce sympathetic activity, potentially improving perfusion. Calcium channel blockers seem particularly effective in attenuating the microvascular dysfunction associated with CSFP. And more recently, nebivolol, a specific beta blocker, has shown promise in improving endothelial function and symptoms, possibly by increasing nitric oxide release. It's often a multi-pronged medication approach.
Let's check in on your learning with another question about this intriguing condition. MCQ 8. Which of the following describes the definition of coronary slow flow phenomenon, CSFP? A. Distal opacification of a coronary artery is delayed on angiography despite obstructive coronary artery disease. B. Distal opacification of a coronary artery is delayed on angiography in the absence of coronary artery disease. C. A tear in the epicardial coronary artery wall associated with atherosclerosis. D. Complete occlusion of a small coronary artery subsegment resulting from plaque disruption. 2-second pause. Now, for a cause that sounds truly dramatic, spontaneous coronary artery dissection, SCAD, a tear in the artery wall that just happens. How is this defined and how often does it occur?
A SCAD is defined as an epicardial coronary artery dissection, a tear in the layers of a large artery wall that is not associated with atherosclerosis, trauma, or caused by a medical procedure, iatrogenic. It's truly spontaneous. While relatively rare compared to typical heart attacks, it accounts for about 1% to 4% of overall acute coronary syndrome cases, and it often shows up in unexpected patient groups.
How does this spontaneous tear actually lead to a heart attack?
The obstruction happens when there's a separation between the layers of the artery wall, specifically the media, middle layer, and adventitia, outer layer. This separation is associated with an intramural hematoma, basically, bleeding within the artery wall itself. This collection of blood then swells and pushes into the central lumen, the channel for blood flow, narrowing it and blocking flow to the heart muscle.
What contributes to SAD happening spontaneously? It sounds so unpredictable.
It's thought that SCAD often involves an intrinsic underlying weakness or abnormality in the blood vessel itself, a vasculopathy. This inherent vulnerability might then be triggered by a precipitating stressor that causes a sudden surge in stress hormones, catecholamines. Examples include intense emotional stress, extreme physical exertion like heavy weightlifting, or maybe certain drugs that mimic stress hormones. It's often a combination of underlying weakness and a trigger.
Are there different theories on how the dissection actually starts? Does the tear begin inside or does it bleed from the outside in?
Yes, there are two main theories. The first suggests an initial tear in the innermost layer, the intima. This allows blood from the main channel to enter the wall and create a false lumen. The second theory proposes the primary event is spontaneous bleeding originating from the tiny blood vessels that supply the artery wall itself, the vasa vasorum. This hemorrhage within the wall then creates the hematoma that obstructs the main lumen.
What does a SCAD patient typically present with? Are there signs that make doctors suspect SCAD over a regular heart attack?
Patients with SCAD commonly present with typical heart attack symptoms. A significant number, maybe 26% to 87%, present with STEMI, the more severe type. Others present with NSTEMI. Suspicion for CAD is often first raised by the patient's demographics, which often don't fit the usual heart attack profile. They're typically younger, often female, and usually have few or no traditional cardiovascular risk factors like high cholesterol or diabetes. That profile is a big clue.
Given it can sometimes mimic atherosclerosis on imaging, how is SCAD diagnosed definitively? What are the angiographic clues?
On angiography, specific clues can suggest SCAD. Things like multiple radiolucent lumens, looking like multiple channels, or contrast dye staining outside the main lumen. Sometimes it just looks like a diffuse narrowing or a focal narrowing, which can mimic atherosclerosis, making it tricky. Unfortunately, studies suggest over 70% of SCAD cases are initially misdiagnosed. This really highlights why being familiar with these appearances and using advanced intracoronary imaging are crucial for better diagnosis.
So what are the key imaging tools for a definitive diagnosis?
The primary tools are intravascular ultrasound, IVUS, and optical coherence tomography, OCT. These give high-resolution images from inside the artery, clearly showing the dissection flap and the intramural hematoma. Coronary CT angiography, CCTA, can also be useful, especially for non-invasive follow-up to monitor healing, particularly in larger, more proximal arteries.
Once SCAD is diagnosed, how is it managed? Is it treated like a regular heart attack with stents, or is the approach different?
Management is complex and often very different from standard heart attacks, mainly because the artery wall is inherently fragile. The primary approach is often conservative management. Observational data shows that the dissection often heals spontaneously in the majority of patients, maybe 70% to 97% if they are managed conservatively and restudied later. The body can heal these tears. However, there are risks. Early complications like recurrent heart attack can happen in 5–10% of patients, usually due to the dissection extending mostly within the first week. So close monitoring is vital.
What about PCI, putting in a stent? Is that an option, or too risky for a torn artery?
PCI for SCAD is generally associated with higher risks and less optimal outcomes compared to PCI for plaque blockages. The arteries are inherently weak. There's a risk of causing new tears, iatrogenic dissection, or extending the existing one. Guide wires can enter the false lumen. Ballooning or stenting can worsen the hematoma. You might need very long stents, increasing risks later. And SCAD often affects distal vessels too small for stents, so it's often avoided if possible.
So if PCI is risky, are there specialized techniques for when intervention is absolutely necessary?
Yes, when intervention is unavoidable, specialized PCI approaches have shown more success. These might include using long drug-eluting stents to completely cover the dissected area, sealing it off. Sometimes direct stenting without predilation is used to minimize trauma. Balloon angioplasty alone might be enough to restore flow sometimes, or a multi-stent approach, sealing the ends first. Even bioresorbable stents, which dissolve over time, are being explored to provide temporary support.
What about bypass surgery, CABG, for SCAD?
Studies show high rates of bypass graft failure, both vein and artery grafts, for SCAD. This is often because the native SCAD vessel heals over time, leading to competitive flow that then blocks the graft. CABG hasn't been shown to prevent recurrent SCAD events either. Given this, if bypass is needed, sometimes vein grafts are considered over arterial grafts to preserve the arteries for potential future needs, although this is complex decision-making.
Another pop quiz for you, focusing on SCAD. MCQ 9. Which of the following is not a typical demographic or risk factor for SCAD? A. Young age. B. Female sex. C. History of atherosclerosis. D. Few or no conventional cardiovascular risk factors. 2-second pause. Sometimes the heart attack isn't about the artery wall itself, but something that travels to it. A coronary embolus. Tell us about this cause of Myocardial.
Right. A coronary embolus is when a piece of material, usually a blood clot, but sometimes other debris, breaks off from elsewhere, travels through the bloodstream, and lodges in a coronary artery, blocking flow. It accounts for about 3% of acute coronary syndrome cases. It's divided into types. Direct, originating from the heart aorta, paradoxical, crossing from veins to arteries, maybe via a hole in the heart, and iatrogenic, caused by medical procedure.
How is it diagnosed and managed? Does it look different?
Clinically, it often looks just like a standard heart attack before the angiogram. However, finding filling defects gaps where dye should be in multiple coronary arteries can be a clue suggesting embolism, as plaque is less likely to strike multiple spots at once. Aspiration thrombectomy, sucking the clot out, is often done. This can help assess the underlying artery. If aspiration restores full flow and the artery looks normal underneath, stents are usually not needed, a key difference from plaque rupture. IVUS OCT can help confirm if it was truly embolic versus plaque erosion. If aspiration isn't fully successful, antiplatelet and anticoagulant meds might be needed. A classic visual sign is the railroad track sign, where dye flows narrowly on either side of the floating embolus.
Next up, a condition with that fascinating name and link to emotional stress. Takotsubo cardiomyopathy, or broken heart syndrome.
Takotsubo, also called acute stress cardiomyopathy or transient LV apical ballooning syndrome, is quite unique. It causes temporary wall motion abnormalities, usually involving the apex, tip, and mid-part of the left ventricle, making it balloon out strangely. It presents like acute heart failure with heart muscle stunning, but crucially without obstructive coronary artery disease. A typical trigger is significant physical or emotional stress right before onset.
Do patients fully recover, or are there risks?
Most patients do have rapid and full recovery of heart function. But it's not always benign. Over 20% can have serious in-hospital complications like heart failure, arrhythmias, even death, at rates similar to regular heart attack patients. So while often self-limiting, it needs careful management. Risk stratification is used, looking at factors like how weak the heart pump is initially, low blood pressure, or arrhythmias to guide care.
Sometimes the heart muscle itself is inflamed, mimicking a heart attack. This brings us to myocarditis.
Yes, myocarditis, inflammation of the heart muscle, has a very varied presentation. It can absolutely present like an acute coronary syndrome chest pain, elevated troponin, but without obstructive coronary disease. That's why it falls under MINOCA. A recent meta-analysis found it in about a third of MINOCA patients, so it's a significant cause. The most common cause is viral infection, often confirmed by PCR testing on a heart muscle biopsy, endomyocardial biopsy, or EMB. Diagnosing myocarditis is crucial because the prognosis varies widely and specific treatments might be needed. About half resolve well, but 12 to 25% can rapidly worsen, leading to severe heart failure or needing a transplant.
And finally, a simple imbalance, supply-demand mismatch.
This refers to type 2 myocardial infarction, T2MI. It occurs due to a mismatch between the heart muscle's oxygen supply and its demand, specifically without an acute plaque rupture or erosion causing a clot. Basically, the heart's oxygen needs drastically exceed the supply it's getting, even if the main arteries are open. This can happen in situations like severe anemia, not enough oxygen carriers, very fast heart rhythms, sky-high demand, or severe high blood pressure, heart working excessively hard. The muscle gets injured from lack of oxygen, even without a primary blockage.
One last quiz to keep you sharp. MCQ 10. Which of the following conditions is specifically described as caused by a myocardial oxygen supply-demand mismatch without acute atherothrombotic plaque disruption? A. Spontaneous coronary artery dissection, SCAD. B. Coronary embolus. C. Takotsubo cardiomyopathy. D. Type 2 myocardial infarction, T2MI. What are the absolute key takeaways from this deep dive into the unexpected heart attack?
I think the first big takeaway is just recognizing that MINOCA is a significant clinical entity. It's not rare, accounting for that 5–6% of heart attacks. And its defining feature is that absence of obstructive coronary artery disease on the angiogram. It really drives home that not all heart attacks fit the classic blocked artery picture. Second, it's vital to remember MINOCA isn't one single disease. It's a syndrome, an umbrella term covering a really diverse range of underlying causes. We've gone through plaque disruption, vasospasm, microvascular dysfunction, SCAD, coronary embolus, takotsubo myocarditis, each very different. Third, this diversity leads directly to diagnostic challenges. Because the presentations vary and standard angiography isn't enough, clinicians often need advanced imaging like OCT or IVUS, and sometimes provocative testing to uncover the true cause. It demands a deeper investigation. And that leads to the final, perhaps most crucial takeaway. Identifying the specific underlying mechanism is absolutely paramount. Why? Because treatment needs to be tailored. What works for vasospasm won't work for SCAD or myocarditis. Personalized management based on a precise diagnosis is key in all these patients. Ultimately, this really underscores the complexity of cardiovascular health. It's not just about plumbing problems. There's so much more going on beneath the surface, and we constantly need a deeper understanding.
This deep dive truly shows us that the heart's vulnerabilities are far more intricate, more subtle than just blockages in the main pipes. It really makes you wonder, what does this new understanding change about how we think about risk, prevention, and even the future of personalized heart care for everyone? There's an explanations. All right, now for the moment you've been waiting for, let's revisit those questions we peppered throughout our deep dive. Let's see how you did.
Let's go through them. 1. MCQ 1 answer, D. They tend to have a higher prevalence of dyslipidemia. Explanation. Remember, we highlighted that MINOCU patients actually tend to have a lower prevalence of high cholesterol dyslipidemia and other traditional risk factors compared to typical heart attack patients. That's one of their distinguishing features. 2. MCQ 2 answer, C. Plaque rupture involves a fibrous cap discontinuity, while plaque erosion involves a thrombus contiguous to the luminal surface without rupture. Explanation. The key difference. Rupture means the cap breaks open. Erosion means a clot forms on the surface without the cap breaking, likely due to endothelial damage. 3. MCQ 3 answer, B. Vasospastic angina. Explanation. Vasospastic angina, Prinz-Metal variant, is the one specifically known for chest pain occurring at rest that responds quickly to short-acting nitrates. 4. MCQ 4 answer, C. Calcium channel blockers. Explanation. We emphasize that calcium channel blockers are the mainstay, the primary medical treatment for preventing spasms in vasospastic angina. 5. MCQ 5 answer, 80%. Explanation. A key physiological point.
The tiny coronary microcirculation accounts for a massive 80% of the total resistance to blood flow in the heart. 6. MCQ 6 answer, C. Coronary flow reserve, CFR. Explanation. CFR is specifically defined as that ratio of maximum hyperemic, fully dilated blood flow to baseline resting flow, measuring the microcirculation's capacity. IMR is a different related measure. 7. MCQ 7 answer. D. Homogeneous distribution of myocardial perfusion abnormalities. Explanation. A defining feature of CMVD is often a scattered or patchy distribution of perfusion problems, unlike the more uniform homogeneous pattern seen with a large artery blockage. This makes it harder to detect. 8. MCQ 8 answer. B. Distal opacification of a coronary artery is delayed on angiography in the absence of coronary artery disease. Explanation. This is the precise definition of coronary slow flow phenomenon, slow die movement without visible blockages. 9. MCQ 9 answer. C. History of atherosclerosis. Explanation. SCAD is defined as not being associated with atherosclerosis. Patients often have few traditional risk factors, making atherosclerosis less likely. 10. MCQ 10 answer. DD type 2 myocardial infarction, T2MI. Explanation.
T2MI is specifically defined as heart muscle injury due to an oxygen supply-demand mismatch, explicitly without an acute plaque rupture or erosion causing a clot.
Thank you so much for joining us on this really detailed deep dive into MINOCA. We sincerely hope this comprehensive exploration has given you some crucial distilled knowledge and maybe a fresh perspective on the complexities of the heart. Remember, the deep dive is here to shortcut your path to being well-informed, bringing you surprising facts and insights without drowning you in jargon. Don't forget to check out those great resources from London Heartbeat Z Academy too. We're already excited at our next deep dive into another fascinating topic. Until then, still curious, stay informed, and keep digging deeper.